Hi, this is Mrs. Lewicki, and this is the fourth of five PowerPoints on the cardiac system. We're going to start, these are the vascular disorders related to the cardiac system that we cover in MP4. We're going to start with hypertensive crisis. Hypertensive crisis is when the blood pressure gets so high that it becomes an emergent situation. Hypertensive emergency occurs over hours to days with a blood pressure greater than 220 over 140 with target organ disease. So you're going to see signs of end organ problems, low urine output, neurological changes, things like that. Hypertensive urgency occurs over days to weeks with a blood pressure greater than 180 over 110, and there's no clinical evidence of target organ disease. The rate of the rise is more important than the absolute value. When we're looking at a hypertensive crisis, we're looking at oftentimes neurological symptoms. So we see sometimes they'll get an intraparenchymal bleed, and that word parenchymal means tissue. So it's bleeding into the brain. And when we get to neuro, we'll talk more about that. But they will sometimes show signs of a stroke. They may have encephalopathy based on that, renal insufficiency, cardiac decompensation, or they could have an aortic dissection, and we'll talk about that in a few minutes. We're going to target our drug therapy to treat the mean arterial pressure. We're going to monitor cardiac and renal function, neurological status, see if we can determine an underlying cause, and educate them on the importance of medications and following their routine and taking them as prescribed. They may be placed on oral medications, or we may give them IV medications to try to lower their blood pressure. And one of those we do is a vasodilator, and it's nitroprusside, or you might have heard it called nipride. So we will use that often in a hypertensive crisis. If that's the case, they need to have an arterial line and they need to be in the ICU. Aortic aneurysm. So an aneurysm is, if you think about a garden hose that sometimes will get a weak spot, that's what happens with an aneurysm. An aneurysm is a weak spot in the aorta, in this case, the aortic aneurysm. Risk factors are coronary artery disease, age. The older you are, the greater of risk you are. Males get it more frequently than females. High cholesterol, peripheral artery disease, carotid artery disease, smoking, older age, obesity. There's a higher incidence in whites and Native Americans for aortic aneurysm. They may be asymptomatic, and sometimes they'll monitor it, so they might find it on their chest X-ray. They might find it, or they may see a pulsation on physical exam in their abdomen. They may have abdominal pain. They could have, for a thoracic aneurysm, because it can be anywhere on the aorta, for a thoracic aneurysm, they may have angina pain and be hoarse. If there's plaque that shatters off with this aneurysm, they can develop a blue toe syndrome. Diagnostics are through chest X-ray. They'll do an ultrasound, and if somebody has a known aneurysm, they'll have regular ultrasounds to measure it. If it's less than 5 centimeters, they'll just continue to observe it. They'll do a CT scan, ECG. They're making sure there aren't cardiac anomalies, an echocardiogram for that reason as well, and angiography. If it's greater than 5 centimeters, they may do surgical intervention. And most places now, they do an endograft repair, and that may be through interventional radiology, or it may be through surgery, the operating room. If it's through the operating room, they have to cross clamp the aorta in order to put in the graft. And by cross clamping the aorta and making that surgical the anastomosis sites, they cut off circulation below that level. So we have to closely monitor their urine output and their extremities for problems due to lack of circulation. So this is a rough idea of what your patient will look like. If it was a radiology patient, if it was a radiological repair, sorry, they wouldn't have a big abdominal dressing. We want to maintain their airway. We want to make sure their head of the bed is elevated. Closely observe for fluid volume deficit and closely monitor their CVP and their urine output. A lot of times they've they were chasing their fluid volume because of whatever's gone on with their aneurysm and their surgery. So we monitor their CVP and we're looking at their central venous pressure to make sure their fluid status is maintained and monitor their urine output. Put them in a position of comfort. We want to splint the incision anytime we cough, reposition them. And we want to make sure we manage their pain because they've had a big incision through their abdominal wall. And again, it's all about the real estate, the anatomical real estate. We want to make sure that they breathe and they must manage their pain in order to get them to breathe. Ruptured aortic aneurysm is a surgical emergency, and we've got a nice picture here of what our normal anatomy looks like. A picture with the aneurysm, and then if it ruptures, you see that blood fills that abdominal cavity. So they can start to tamponade those surrounding organs. And because it's fast bleeding from the aorta, it's a big vessel, many do not survive to make it to the hospital. You could also get a dissection of the aorta, and that's when the intima starts pulling away from the vessel wall, and men get that more often than women. Diagnostics are the same. They may do a TEE, would be the only other thing, but they have sudden severe pain. It's usually chest pain. It can be so severe it's pulling off the aortic valve. So it really depends on how far it's dissecting. They have neurodeficiencies. They may have them. So a decreased level of consciousness, or they may look like a stroke depending on what area is not getting blood, oxygenated blood. They would treat it doing an endovascular repair, and it's a surgical emergency if the acute ascending aorta is involved because that can involve the aortic valve. Your nursing interventions include maintaining the airway, continuous ECG monitoring. They would need an arterial line for their blood pressure and other care, same as a AAA repair. Now, I didn't say this in the earlier slide, but for both of these, because there may be anastomosis sites, we really have a fine line for keeping their blood pressure under control. So we need it to be high enough to perfuse their kidneys, but not so high that it blows the graft. So we have usually a narrow parameter that we're trying to maintain their blood pressure in.